Hello, future doctors. How are you all? Welcome back to MedSteps YouTube channel. I'm your Dr. Anand Jana, and today we are continuing our general surgery series with a very important and commonly encountered surgical infection, that is cellulitis. Whether if you are preparing for internship or preparing for your general surgery and rotation or exit exam, this video is very helpful for you. So now let me ask you a question. A patient comes to the emergency room with a red, hot, swollen and painful leg. Is it simple cellulitis, an abscess, or deep vein thrombosis, or something much more dangerous like necrotizing fasciitis? As a surgeon, as a general surgery department medical student, making the correct diagnosis early can mean the difference between is saving a limb and losing a limb, or even saving a patient's life. So, in today's section, we will learn about cellulitis from basic to advanced surgical concepts. We will cover the anatomy and physiology and causes, and what are the microorganisms will cause cellulitis, and the pathophysiology and clinical features, and some differential diagnosis and investigations and image findings and treatment guidelines, antibiotics and how to manage if any surgical indications, how to do that procedures and complications, and in asked cases how the doctor can ask Viva questions and high yield exam PLs we are going to discuss in this video. By the end of this lecture, you will not only be able to diagnose and manage cellulitis confidently, but you will also understand how to differentiate it from dangerous surgical emergencies such as necrotizing fasciitis and severe diabetic foot infections. So, grab your notebook, get ready to think like a surgeon, and let's begin our comprehensive general surgery masterclass on cellulitis. So, this is the image you can see here. This is cellulitis. How I'm telling, because mostly cellulitis you can see in unilateral limb. Okay, so in this cellulitis, first of all, we have to understand how that name came. So this is cellulitis, right? In that cellulitis, the cellulitis name originates from cellula. Cellula means small space. Itis means, as you know, that is inflammation. Okay, so before giving any antibiotic, the cellulitis frequently progress to sepsis, and it be like gangrene and death. So the introduction of penicillin dramatically reduced the mortality. So that's why this is how that name came. The small space infections is known as cellulitis. Okay, if you're seeing definition, the cellulitis is a acute diffuse spreading bacterial infection of the skin and subcutaneous tissue, and it's characterized by edema, and it's characterized by erythema and warmth and swelling and tenderness and edema without a localized collection of pus. How you can differentiate with the erysipelas and cellulitis means the cellulitis primarily involves in dermis and subcutaneous fat and superficial facial occasionally. Okay, so it's like unlike an abscess, cellulitis has no well formed pus cavity. So this is the things. So now we can see some clinical importance, because in exam Viva point of view, this clinical importance are very important. Okay, so in this clinical importance, the cellulitis is one of the most common surgical infections encountered in our accidental emergency department and surgical clinics and diabetic food clinics and trauma wards. Actually, it can progressively and it can rapidly progress to abscess and very severe and life-threatening condition, that is necrotizing fasciitis. Next we can see septic shock and we can see that is multi-organ failure. Okay, why every surgeon must know cellulitis? Because cellulitis can mimic, because this cellulitis may present with early necrotizing fasciitis and diabetic foot infection and post-operative wound infections and deep space infection. If you miss the diagnosis, the patient might be miss their limb in whole life. So that's why this is very important. So whenever in exam point of view, I will tell some important points. In the cellulitis mostly caused by streptococcus pyogenes. Okay, this is the main organism. And if any patient coming with cellulitis coming with the pus, then you have to suspect the patient have staphylococcus aureus. The organisms is causing pus. Okay, so mostly cellulitis means we can see cardinal signs, means rubor means redness, color means warm sensation, tumor means swelling, okay, and functional means reduced function. Along with that, dollar means painful skin you can see. So these are the things you can see in cellulitis. So the borders will be like poorly defined. You can see here you can't differentiate that borders properly, so it's poorly defined. Along with that, no fluctuance, and you can see whenever patient getting cellulitis, the diabetes is the major risk factor. Okay, so in most dangerous differential, if you want to give means, that is necrotizing fasciitis. Okay, so we will see little anatomy of skin layers, then easily we can understand how that pathophysiology and everything is going on in cellulitis. Okay, so here we can see some skin layers. This is the skin layers. We can see skin. The skin layers we can see like epidermis and dermis and subcutaneous tissue and deep fascia, subcutaneous tissue and deep fascia and some muscles. And this cellulitis usually involves in mostly this dermis and subcutaneous tissue. Here you can see some blood vessels and everything. So the blood vessels, everything here, what will happen, the skin receives blood from perforated vessels and the dermal plexus and subdermal plexus. So because of the thing here, what will happen, poor perfusion. Okay, so the poor perfusion will predispose to the infection. So this is the main concept. Because of the thing, then after the bacteria, if you're seeing in lymphatic drainage, the lymphatics will remove the bacteria and debris, and we can see inflammatory mediators. So because of the thing here, we can see this is the, for example, this is lymphatic system. Okay, lymphatic drain. So if any obstruction happen here because of this bacterial, then the patient will get highest risk of cellulitis. Okay, so because of this thing, the patient will get cellulitis. So you can see some nerve supply. In this nerve supply, the cutaneous sensory nerves will become transmit. So patient will get pain, burning sensation and tenderness. Okay, so in clinical correlation, the cellulitis mostly commonly affects lower limbs and diabetic feet and surgical wounds and traumatic wounds. Why diabetic feet means, whenever patient getting uncontrolled, if patient have uncontrolled diabetes, they will get distal segmental polyneuropathy. Okay, because of this diabetic neuropathy, the patient is not going to get any sensation. If the patient got any tear or any hit, slowly the bacterial infects organisms will go inside and it will mix with blood. Then after, the lymphatic drainage will try to take out that bacteria from blood. Then what will happen, the bacteria will obstruct the lymphatic drainage. Then that part will get that bleeding and the cellulitis, the bacteria will grow and it will cause cellulitis. So mostly the patient getting cellulitis means because of portal of entry, and along with that skip lesions we can see in the 2 by 2 lymphatic spread. Okay, so these are the things. Now we have some dangerous areas. If any patient getting cellulitis in face, we call this is dangerous triangle, because the infection can spread to intracranially. Okay, so that's why we call this is dangerous areas. Along with that, another one, hand. If you're seeing here in this hand, it can may spread to, we have here some tendons, it will spread to tendon sheaths, and it will cause problem with the movements and everything. Next, here we can see this is orbital cellulitis. You can see bulging and swollen eyelid and discoloration of redness in the surrounding skins. So we can see diabetic foot also. Diabetic foot also can mimic like cellulitis. If patient getting diabetic foot, they are very risk of osteomyelitis, gangrene and amputation. So now physiology of cellulitis. Here you can see this is the normal skin, and this is cellulitis. Okay, so in this normal skin, for defense mechanism we have skin protects through the, because we have one physical barrier. So the physical barrier will made by keratinized epithelium. Okay, so skin will act like defense, protective. Okay, so we have some chemical barriers, that is like sebum and low pH and antimicrobial peptides. So we have some immunological barriers, that is neutrophils and macrophages and Langerhans cells will help to defense. So if you are seeing clinical relevance, the cellulitis will develop when bacteria breach these defenses. Say for example, the patient got some tear here, then the barrier everything will become break, then the bacteria will enter inside. Okay, and it will cause cellulitis. So next we can see some common organisms can cause cellulitis. So the cellulitis we can divide into two different parts. One is non-purulent, second one purulent. Non-purulent means it's we have two organisms. Non-purulent means no pus. Purulent means the cellulitis present with pus. Okay, so in non-purulent we can see Streptococcus pyogenes. Next one we can see group A, Streptococcus. Okay, next one purulent cellulitis, we can see the most common organisms will be like Staphylococcus aureus. Next one MRSA. And we can see some risk factors. Risk factors will be like local risk factors will be like trauma, we can see abrasions, and we can see like ulcers and surgical wounds and burns. So these are the risk factors of the local risk factors of the cellulitis. Next we can see some systemic risk factors will be like, we can see diabetes, obesity and immunosuppression. Next we can see HIV and steroid therapy. Next we can see malnutrition. So these are the risk factors. In some mostly common causes will be like, in some special cases, because of some primary cause the patient will get cellulitis. So in special cases we can see human bite. Human bite, we can see, we can tell like Acanella. Next one, cat bite, we called Pasturella. Next we can see water exposure, like Vibrio species and Aeromonas species. So these are the things can in special cases. In special cases, we can see human bite, cat bite, water exposure can cause this type of cellulitis. Okay. So next we can see little pathophysiology. So we have some common pathogens we already discussed before, that is coagulation negative staphylococci, and in transient skin flora we can see staphylococcus aureus, streptococcus pyogenes and gram negative bacterial fungi. So here what happen first, in this is the normal skin. In normal skin we can see three different types of layers: epidermal layer, dermal epidermal junction, dermal layer and subcutaneous fat. So in this spot, if any problem patient getting missed, then we call that is cellulitis. So the pathogens will enters directly to inside. So the pathogens in deep dermis and subcutaneous fat. So if you're seeing here, what will happen, the skin will break. So break in skin barrier may not be obvious on entry of pathogen. So if any patient have cracked skin or recently surgery done, a direct inoculation of because of trauma or because of diabetic neuropathy, if any patient get loss of sensation, they got any tear, and the bacteria, the organisms will insert inside. Then after we can see inside the host, the organisms will become multiplication. So here what will happen, whenever it's becoming multiplication, here we can see the bacteria got multiplication, then after we can see some inflammatory response. In inflammatory response, the cytokines will activate and it will activate immune response. Then what will happen, the local inflammatory response in the skin, accumulation of pus bacterial with white blood cells, then after systemic inflammation. So here whenever the inflammatory response activated, then what it will do, it will cause vasodilation. Because of that vasodilation, the patient will get capillary leak, then patient will get edema. Okay, so next we can see here some neutrophils recruitment we can see, and it will cause cellulitis. So the local inflammatory response in skin, you can see like pain, warm, edema and erythema, redness with distant and vesicles or bullae in rare cases. If the pus is accumulated because of staphylococcus aureus, the patient will get abscess formation. If patient has systemic inflammation, the patient will get fever, chills, malaise and sepsis. So here the bacterial infection organisms penetrate to the blood vessels. As I told you before, it will penetrate to blood vessel, then you can see vasodilation. Then the bacteremia means the presence, the bacteria is presenting in blood. So here it will distant spread to the bone. If it's spreading to the bone, then we call that is osteomyelitis. If the distant spread to endocardium, inner lining of the heart, then we call endocarditis. So same to same, the cellulitis will spread into the blood, then after from blood the lymph nodes, through lymph nodes it will go to the lymphatic drainage. So here the infection spread to the lymph nodes, and if any patient getting inflammation in lymph nodes or obstruction, it will cause lymphadenitis. Then after infection spreads through the lymph vessels, then we call ascending lymphangitis. Okay, so these are the things. Now we already discussed about risk factors and in MRSA cellulitis. So this is the physiology. Okay, along with that, in cellular events, what other things will happen? So whenever the cytokines will release, the pro-inflammatory markers will release. Here we can see the bacteria will enter the tissues. Then after we can see macrophages activation. Macrophages will activate, then after it will release cytokines. What are the cytokines? We can see here tumor necrotic factor alpha, interleukin 1 and interleukin 6. Okay, so because of these things, because of this interleukins, cytokines, we can see inflammation and it will form into clinical redness and swelling. Okay, so in pathology cases we can see here that these are the things. Gross pathology means it will affect the skin appears. So this is the skin appears. We can see like red, warm, swollen, tender, and poorly demarcated margins. Okay, it will look like this in pathology if you are seeing that image properly. Next one we can see histopathology. In histopathology, we will take that layer, and if you are sending for histopathology, you can see the microscopy will show this type of image. So these are the dermal edema you can see in histopathology case. Along with that, you can see dilated capillaries, and you can see neutrophils infiltration. You can see this type of cells. The cells, everything we call neutrophils. The neutrophils will get infiltration, and the tissue will become inflamed. Okay, so cellulitis is divided into two different parts. One is non-purulent and purulent, and some complications. So I already mentioned before, non-purulent means no pus and no abscess. Purulent means associated with abscess and pus formation. In complicated cases, we can see deep infection, necrosis, and systemic toxicity. Okay, next we can see here that is clinical features. In clinical features, next we can see here some clinical features. The clinical features will be like pain, swelling, redness, pain, swelling, redness, fever, and chills. So the clinical presentation will be like a patient develops with red, hot, tender, swollen skin and with fever. So same to same like cardinal signs. Okay, in late features, we can see abscess formation, necrosis, and sepsis. Okay, so we have some red flag signs. In this red flag signs, if any patient coming with pain out of proportion, means unbearable pain. If patient getting, means we have to suspect necrotizing fasciitis. So pain out of proportion. Along with that, if you are seeing any crepitus or skin necrosis, rapid progression, or patient in shock, then you have to suspect patient have necrotizing fasciitis. So now these are the things very important. Whenever patient coming to hospital, history is very important. In history taking, we have to ask when the symptoms begin, and any traumatic incident happen, or any insect bite, or any animal bite, a patient have any diabetes, or patient have any fever, or previous cellulitis. We have to take proper history. Then after, in Viva, the mostly the doctor can ask that very commonly asked question, that is which most common organisms can cause cellulitis. That is Streptococcus pyogenes. Don't forget, because this is the main question the doctor can ask mostly in Viva settings. So next one we can see here, that is physical examination. In physical examination, mostly we have to focus on inspection. Next one, palpation. So in physical finding, in physical examination, in inspection, we have to look for redness, swelling, and skin breaks and ulcers. In palpitations, we have to assess for warm sensation and tenderness and induration. Next one, fluctuation. So these are things very important. So the important findings in cellulitis, we can, if patient have the abscess will be like fluctuating, it's not a simple cellulitis. Okay, so next one we can see here, the patient while during Viva or ask setting, the doctor can ask, tell me the differential diagnosis of cellulitis. Then whenever the doctor is asking about a differential diagnosis, always don't mention the current diagnosis. Okay, so you mentioned about cellulitis, so the doctor is asking another differential diagnosis. So what are the things we have to do? We have to tell other conditions, like for example abscess. In abscess we can see fluctuant swelling. Okay, next one, cellulitis means diffuse redness. On the doctor, if the doctor is asking why you are telling that abscess, we have to explain properly, that is because of fluctuant swelling we can see. Next one, necrotizing fasciitis. In necrotizing fasciitis, the pain we can see out of proportion. Okay, next one, another differential diagnosis will be like DVT, because the DVT can cause in unilateral mostly. So we can see the Hoffman's sign means cough, swelling. Hoffman sign, sorry, the Hoffman sign will comes positive because of cough, swelling. Next we can see no redness pattern. Okay, next one we have another condition, that is erysipelas. Erysipelas means it raised sharp margins. Only this is the same main difference we can differentiate with the erysipelas will be raised sharp margins, cellulitis diffuse margins. Okay, next we can see gout. In gout, joint centered inflammation we can see. So these are the differential diagnosis we can give for cellulitis. Okay, so you can see this image, this is the cellulitis. Okay, diffuse margins here. Okay, unilateral. So next, investigation. How to do investigation in cellulitis patient? So in investigation, first we can go with labs. In labs, we can go with CBC. In CBC we can see leukocytosis, means increasing WBC count. Next we can go with CRP and ESR will increase because of inflammation and markers. Next we can do blood culture, only if you are suspecting if septic. Next, imaging. In imaging we can do ultrasound. It will detect occult abscess, and we can do X-ray. If you are suspecting gas gangrene or osteomyelitis, you have to do X-ray. Next, CT scan. The CT scan will define deep tissue spread. Okay, and if you are suspecting for necrotizing fasciitis and osteomyelitis, how much that bone damage and everything, then we have to go with MRI is the best option. Okay, so in ultrasound, if we are doing ultrasound, in this ultrasound, if patient have cellulitis, we can see cobblestone appearance. Classic exam image they will give, that is cobblestone appearance. Okay, next in X-ray you can see soft tissue swelling and gas suggests a necrotizing infection. Okay, so here we have one classification for differentiating mild, moderate, severe cases. The classification we called IDSA classification. So we have mild. In mild cases, we can't see any no systemic signs. Next we can see moderate. In moderate cases, we can see systemic symptoms presents. Next, in severe cases, we can see sepsis or deep infections. Okay, so these are the classification of sepsis, classification of cellulitis. Okay, now management. How to do management for cellulitis? So in management, first main goals will be like we have to eradicate the infection, and we have to prevent abscess, and we have to prevent sepsis, and we have to preserve the limb. Okay, so here if patient have mild cellulitis, we can go with oral antibiotics. Okay, the oral antibiotics like we can go with first generation. If patient have non-purulent cellulitis, mild case, we can go with first generation cephalosporin like cephalexin 500 milligram orally every 6 hours for 5 to 7 days. Okay, or you can go with amoxicillin clavulinate 80-75 by 125 milligram BID. Okay, if you're suspecting MRSA at risk, then you can go with trimethoprim and SMX, or you can go with doxycycline. Okay, so in non-pharmacological management, we have to give limb supportive care like limb elevation or more amount of hydration and analgesics. Okay, so these are the mild cellulitis management. So along with that, you can divide this management into two different types. One is non-purulent cellulitis, next one purulent cellulitis. So in non-purulent cellulitis, the main organisms will be like Streptococcus pyogenes and group B A Streptococcus. So we have to go with oral antibiotics, that is first generation cephalosporins. Along with that, penicillins like dicloxyxylin and penicillin, in severe case clindamycin. So if purulent cellulitis, the main thing will be like incision and drainage, purulent cellulitis. And the main purulent cellulitis causing organisms will be like Staphylococcus aureus and MRSA. The oral options, if you are suspecting MSSA, then you have to go with dicloxyxylin and cephalosporins. If you are suspecting oral MRSA options, we have doxycycline, TMP, and clindamycin and linezolid. Okay, so these are the tricks we can give. Next one, surgical management. The surgical management main indications will be like abscess, necrosis, compartment syndrome, and necrotizing fasciitis and failed antibiotics. If patient have pus, we have to must be drained. Then after antibiotics alone can't penetrate abscess effectively. That's why we have to incision drainage is very important. So these are the things. Next we can see operative procedure. In operative procedure, we can see incision and drainage. So first we have to take consent from the patient, then after we have to mark the site, then after we have to give anesthesia and local or general anesthesia we can give, then after we have to do incision over maximum fluctuance. Wherever the patient have like more over maximum fluctuance, then we have to do drain the pus in that spot. Why? Because maximum fluctuations we are seeing means the patient have abscess. So break loculations and we can do finger dissection. Then after wash the cavity with normal saline, and we have to packing if indicated. So structures at risk, because we have to, as a surgeon, we have to know properly that anatomical structures, that landmarks and everything, because while doing this incision drainage we can damage the nerves, arteries and veins. Okay, so that's why these are the things very important. Next we can see complications. The complications we can divide into two different types of complications. One is local and another one systemic. In local we can see abscess, tissue necrosis, Next we can see osteomyelitis. Okay, next one systemic. In systemic we can see like bacteremia, sepsis. Next one septic shock. Okay, life threatening case will be like necrotizing fasciitis. If you are suspecting patient have necrotizing fasciitis, emergency surgical intervention is very important. Okay, in emergency management, first we have to go with primary survey like airway, breathing, circulation, disability and exposure. Then after we have to start a sepsis bundle, like we have to do blood culture. Then after, based on sensitivity, we have to give intravenous antibiotics and intravenous fluids, and we have to, patient have sepsis, so we have to check lactate measurements. Then after we have to control the source. Okay, based on recent guidelines, the current recommendation will be like whenever patient admitting to the hospital, first we have to start early antibiotics and ultrasound for suspected abscess. Then after we have to avoid unnecessary antibiotics for non-infectious mimics. Then after we have to do early surgery if you are suspecting for necrotizing infections. So in ASCII station, the doctor can ask like examine patient with swollen leg and expected findings like redness, warmth, tenderness and edema. Then you have to suspect the patient have cellulitis. Okay, so I got one patient. Okay, when I did the general surgery department, that time I got one patient that is 60 years old, diabetic male with foot ulcer, fever and red swollen foot, and the white blood cells in CBC, that white blood cells we can see 18,000, and the diagnosis will be like I told cellulitis, but the doctor said like the patient have diabetic foot cellulitis. So how to manage that patient? So I told intravenous antibiotics based on that purulent or non-purulent based on organism. Next one, glycemic, we have to control the properly glycemic control. Then after we have to do debridement if needed. Then after we have to do proper food care. Okay, so these are the things. So at last, for your exam point of view, I am repeating that high yield points, that is most common organisms for cellulitis, that is Streptococcus pyogenes, and the MRSA causes purulent cellulitis, and in ultrasound we can see cobblestone appearance, and erysipelas has raised sharply demarcated borders, and pain out of proportion means we have to suspect necrotizing fasciitis. We can see gas in tissue, then we have to do surgical emergency surgical intervention. If patient have any pus, purulent discharge, we have to drainage that to total that pus. If diabetic foot cellulitis means it may 100% it may be hide osteomyelitis, so we have to rule out osteomyelitis also. Okay, so these are the things. If you have any doubt, you can ask me in comment section. If you didn't subscribe my channel, like, share and subscribe. If you have any doubt, in next video we will discuss about the thing. Okay, if you didn't watch, right now we are in general surgery series. I already made a video about thyroid along with that pancreatitis. If you didn't watch that videos, go and watch and learn. If you have any doubt, you can ask me in comment section. Okay, so till that time I'm signing off. We will meet in our next video. Till that time, take care.